for people. Hello? Welcome back to the next session. Innovations to tackle HIV stigma and discrimination, undetectable, untransmittable, and decentralization of care. And the specific title of the session is the impact of new testing tools, including HIV-ST and methodologies in addressing stigma and discrimination, the contribution of the faith sector. But now we're going to listen to, we're supposed to have Rachel, but Rachel is not here. We have her colleague, Paul Vischer, who works at WHO supporting countries on innovative testing and virtual interventions. Welcome to you.
Thank you, everyone. I'm just representing Rachel here. Apologies, she couldn't be here because she has another conflict. But I would like to take you all through a short presentation that we've put together on some of the innovative tools that can help us with regards to stigma discrimination, and also how we are going to be, how we can take the help of interfaith organizations in doing so. So with regards, stigma and discrimination, as we all know, I think it still remains in the health sector. It's still a big problem with our sector, which needs to be dealt with. We've seen some reports from UNAIDS in 2019, which says that about 25% of the PLHIVs experience some form of stigma discrimination at healthcare settings. More than 30% of women living with HIV have been experiencing stigma discrimination, basically from healthcare providers asking them various types of questions or asking them to avoid pregnancies, etc. PLHIVs also, basically perceive very high level of HIV-related stigma, are about 2.4% more likely to delay enrollment into treatment. So these are some things that, still exist, and some things that we need to deal with as far as the health sector is concerned. And we feel strongly that the faith leaders and faith-based organizations play an extremely important role in order to be able to influence communities, in order to influence healthcare providers and settings, to be able to improve the situation for the community moving forward. So WHO is launching the new key population guidelines here in Montreal. The details are here on your screen, which basically gives us a snapshot of what are the new strategies and the things that WHO is recommending moving forward for key populations. So, I just heard a few others talking about this as well, that men accessing treatment services or services in general has been an issue. And I think this is globally. So I just wanted to say that, why is it important to reach men? For example, if I take a case of Eastern and Southern Africa, we are seeing that men have less access to testing because they are more stigmatized for some reason. Men are less likely to access ART and hence are less virally suppressed. Reaching testing and linking them to ART has been a challenge because they feel, I've worked with Eastern Southern Africa, and so I know that a lot of men feel that they don't want to have like a separate room for testing for men. They want to be mainstreamed so that there is less stigma attached to going in for a testing. So in short, we need to reach men and we need to address the barriers that they face. So what are some of the barriers that men face? Basically, fears of stereotypes and a lack of male-friendly services, flexible healthcare arrangements, social support having any kind of demonstrated promise. Include men in we fail to include men as far as policies and strategies are concerned. We need to include more of men to when we are discussing strategies and policies, so that we are able to include barriers and challenges that they've been facing for so long, and make sure that they are kind of addressed in our programs moving forward. Improve uptake of testing and linkage, so workplace settings, virtual settings, even male-friendly health facilities, and men gathering, including at faith settings. So one of the tools that I want to talk about today in terms of innovations, as we all know about HIV self-testing. So, self-testing is a test that is done, you can do it on your own, at your own convenience and confidential environment. And then if you test positive, then you probably need to take a confirmatory test. So WHO recommends HIV self-testing because it has shown that it is safe and accurate. It is highly acceptable amongst communities and populations. It improves access to testing, and basically WHO recommends that HIV self-testing should be promoted among people who would otherwise not go in for a test. So we know that a lot of populations, because of fear of stigma and discrimination, often don't reach a facility to get tested. And self-testing has been identified as one such tool that can actually help us overcome this barrier and test many, many more people. And like I just mentioned, in case you test positive, in case somebody tests positive in a self-test, then they need to go in for a confirmatory test. If they test negative, then that's a negative result, but then you can keep testing based on the kind of risk behavior that you foresee for your client or patient, and that's how we can move ahead in the process. So where to deliver self-testing? We know that there are a lot of places where we've tried to deliver self-testing, and WHO in their guidelines on self-testing have noted a few places which can be used. And one of them I want to highlight today is faith-based organizations or faith-based settings, which actually help in promoting new tools, new guidelines, new policies, and also talk of new ways in which we can actually improve access to testing, treatment, or any other services for our populations. This is just a quick snapshot of HIV self-testing policy and implementation across the globe, region-wise, of course. And we see that there has been a huge jump in the number of countries that have actually started, implementing HIV self-testing either as a demonstration project or as a national scale-up, and also started having HIV self-testing as part of their guidelines and policies. But this jump that you see has been in the past 2 years because of COVID. A lot of countries did use a lot of self-testing in order to continue providing services to the populations. But we still have a long way to go because we are at 51%, but we need to increase the number of countries who start using this and basically improve number of options that people have for testing. So as you might know, we have the pre-qualified list of WHO pre-qualified list of tests that are available. I think here we've only listed, now we have the 6th one also. Okay, so you must have read on Twitter or somewhere yesterday that we finally have a $1 test by in vitro diagnostics, which is actually going to be like a game changer, because a lot of countries felt that self-tests were turning out to be very expensive when they were imported or, actually being to be used by the key population. But the $1 test kit, I think, is going to kind of bring about a change in that game, and we will be able to make it more accessible for populations to use. So I just wanted to show you a quick impact of higher case finding and therefore linkage to ART. So this is a case study from 2018-19 where we saw that a lot of self-test kits were distributed amongst the population, which gave us a very high case finding as compared to the normal case finding that we would have done through traditional testing. And therefore, if you see the linkage rate to ART was also very high, which was at 91%. We also saw that the first-time testers, when we were testing people with HIV self-testing and we asked them if they had taken a test before, we found that a very high number of people were actually first-time testers, which means that if we wouldn't have provided them that option of a self-test kit, probably they would have been, not tested even now. And therefore, the impact on ART demand following community-based HIV self-testing has also increased. So because there are a lot more people now getting tested for HIV and then therefore, being confirmed for HIV test, there is a high demand of ART amongst this population as well. I'm going to skip this slide. There are, just wanted to highlight here that HIV self-testing distribution, the ratio between male-female, and the number of people turning positive is seen to be higher among men. But as we know that men is one population that is often neglected, and we do need to consider them as a priority population and reach out to them with services based on their convenience, needs, and preferences. Along with HIV self-testing, we now know that there is hepatitis self-testing which is available as well. And I think with the whole self-testing trend with COVID and with HIV already being implemented at a large scale, I think hepatitis self-testing is also something that programs need to pick up in countries and provide that extra tool or an option for populations to actually get themselves tested for hepatitis as well. Like I said, COVID-19, WHO also recommends COVID-19 self-testing, and it's now widely available in most countries, I think, at pharmacies and various pickup points. Similarly, we can replicate the same kind of model that we have for COVID-19 that we implemented so quickly over the last 2 years. We could do the same thing for HIV as well as hepatitis. Another tool that I wanted to talk about was WHO's recommended social network testing, which is mainly reaching out to partners, spouses, or even social networks of high-risk behavior individuals or positive individuals, and then testing them further in the process to be able to identify and diagnose more and more people. WHO considerations for implementing social network-based testing is that it is not mandatory. It is not something that you will be forced to do, but this is a step that every healthcare provider should take to be able to identify or help people diagnose themselves and get on treatment as soon as possible. So it's important that we provide confidential confidential testing services, avoid any kind of harm, make sure that there is no stigma discrimination attached to any kind of social network-based testing or index testing, and you're not placing the person at harm at any point. So these are some things that needs to be considered while implementing this tool, this particular strategy. The next thing that I wanted to highlight here is virtual intervention. So I'm sure everybody's heard of virtual interventions. We know that, populations are now moving virtual. You don't find many populations like we used to a few years ago as, street-based sex workers or soliciting on the streets, etc. We all find them now on dating apps and social media platforms. And WHO and UNAIDS strongly feel that we do need to move our programs virtually as well to be able to reach out to this population, mainly who are like unidentified populations, or they are non-identifying. So by non-identifying, I mean that populations who don't necessarily identify themselves as key populations, but are equally vulnerable and in need of services. So, a lot of times people ask me this question as to why do we really need to go virtual? We have robust traditional programs going on for decades. Do we need to go virtual? Do we need to take this step? So, the data points that you see on this slide is the answer for that. We see that 4.80 billion people are active internet users today, and almost 2.5 hours of the entire day is spent on social media. So, this includes younger populations as well as older populations, and so there's nothing like virtual interventions is only meant for the younger populations. It's not like that. It's mainly for anybody who uses the internet or even phones. So it's not necessarily just an internet-based intervention. It can be accessible over a normal, simple phone as well, through a phone call known as virtual case management. This is an example from Vietnam where we implemented virtual case management and virtual interventions for people to be able to order HIV self-test kits on a platform online. Just as you order food on a food delivery app, you order a self-test kit and it gets couriered to you at your home through a service. It's as quick and as confidential. You can have it couriered at a convenient location so that you're not worried about somebody seeing it or anything else. And we had great results with this, and we also linked PrEP services with this. So if you test negative, you can also order yourself a bottle of PrEP. It's the same way. Just click online, order yourself PrEP, and then you can get it delivered at the convenience of your home setting. This is an example of from Malaysia where we also developed a platform called jomtest.org. Again, a similar platform where you can just log in, fill in a few questions in terms of your name, etc., and then you can quickly order yourself a self-test kit, and it gets delivered to you at your convenient location. So this was launched in about November 2020. We had about 439 participants and 343 completed a pre-test survey. We had 243 packages delivered. 69 actually completed their test results. We found 5 positive. We also had a post-test survey that helped us actually understand some of the barriers or challenges and then helped us improve in our program. So this is very exciting. I think we are launching the policy brief on virtual interventions on 30th of July at the conference. So if anybody is available and free to attend, please do walk in. It's in room number 519B at 2 p.m. on 30th. It'll be great to have you. We are going to talk about this policy brief and why was it important and what it all entails. So use equals to U, as we all know, for the past more than 20 years, we've known that ART reduces HIV transmission, right? But we also agree that for the past few years, scientists agree that the risk is not just reduced, it is actually stopped completely. We need to promote this more often. We need to ensure that use equals to U is a message that goes out to people, and we are able to actually make use of everything that U is equals to U can, the change that U is equals to U can bring about amongst our populations. Thank you. I'd like to acknowledge our team, Mohammed Jamil, Cheryl Johnson, and now we have Rachel in the room as well. So. If there are any questions, you can feel free to ask her as well. Thank you.
Thank you, Purvi. If you forget everything she said, remember 5 C's: consent, confidentiality, counseling, correct results, and connection. Our next speaker is still stuck at the airport in South Africa, but we have Susan, and I don't think she needs introduction from me. She will speak on behalf of GIBSA. Welcome. And yeah, sorry.
Here I am going to have to maybe I can move this back. So I'm so short I can never see those slides. I am so thrilled to be able to speak on behalf of GIBSTAR. I first visited and saw what they were doing right after they had started the community post. They probably only had 6 of them. And we were doing technical visits to all the 10 Faith and Community Initiative countries for PEPFAR. And I was so shocked at what I saw already happening, and I just thought, like, we have got to learn, is this really going to work, and can it be replicated? And how many of you have ever met GIBSTAR? Raise your hand. So, not many of you. He's one of those people a little bit like Echo. You know, they're so charismatic, you just think, well, would anybody else be able to do that intervention and have it work as well as they do? But any person who is charismatic has qualities that they are implementing. If they're effective, there are qualities that they are implementing and using that can be replicated, and we have shown that and learned that from GiveStar. And so the model that I'm going to talk with you about now has been replicated in Nigeria and in Zimbabwe. It was replicated with greater fidelity in Zimbabwe, so it works better in Zimbabwe when you replicate with fidelity. And in fact, the government of Zambia has supported scaling it to a large number of regions of the country. And again, they're not doing it quite to the fidelity that we would hope, but they still are really showing dramatic improvement over your standard clinical models. So these are called faith-engaged community posts. There's a PEPFAR solution on the PEPFAR platform about it, and all the implementation tools you would need to implement it, from spreadsheets to Word documents and to videos, are there with some technical assistance available. So that having been said, I want to talk to you about the impact of new testing tools, including HIV self-tests and methodologies in addressing stigma and discrimination, and particularly the contribution of the faith sector. Next slide, please. Can you move the slides, please? Oh, can you guys, sorry, can you all just do it for me? Is that okay? Yeah, great. Okay, thanks so much. It was fascinating the way that GiveStar tells the story of how he first discovered this model. He was sitting there and realizing they were basically getting almost no new cases of HIV diagnosed as they sat there in their clinic, nice clinic, waiting for everybody to come. And so he called a meeting of everybody, including like the doctors, the nurses, the gardener, the guard, the receptionist, the person who did the cleaning, everybody. He thought, like, we have got to solve this together. And he asked them, if you had to figure out the barriers that are keeping people from coming to us, what do you think they are? And they identified these barriers to getting into HIV treatment. Stigma was at the top, if you see that. The cost to travel to the facilities, exactly what Echo said. Poor customer care. They did not really feel like they were receiving that compassionate care that we've been talking about all morning. Health facilities are often working in isolation, and it just takes too much time out of a busy day to go sit and wait 3 to 4 hours to be treated. So they decided that they were going to deploy decentralized one-room community posts located in markets, bus stops, churches, and fishing camps. And the faith champions, they were going to engage faith leaders who lived in the community and whose main motivation was that they cared about the people in their community and wanted to help them. But they were going to engage faith champions and other community leaders, but it ended up being primarily about 90% faith champions, because they were the ones who really answered the question, what's your motivation? I want to care for the people in my community. They were the ones more likely to say that. But they were deployed into their own communities to find, treat, and care for those living with HIV, and also to address COVID-19. So it occurred in the community. It was faith engaged, and how they did it, this recipe I talked about yesterday that he says every morning to the people that are working on his team when he does this 10-minute little pep talk before everybody starts out. R is respect, E is empathy, C is compassion, I is integrity, P is passion, and E is ethics. Next slide, please. So I have seen a lot of his slide sets before, and the thing I really like about these slides is he clearly really thought about the topic, and these next 2 slides are really helpful, I think. Key enablers and drivers of stigma and discrimination in local communities and in faith communities. This number 1, misinformation and misconceptions. Please speak slower. Got it. Thanks. Sorry. So number 1, building of the capacity. Go back a minute, please. Go to the previous slide, please. Great. Key enablers and drivers of stigma in any community, local faith community. Number 1, misinformation and misconceptions about HIV. Number 2, reduce testimony from influential role models. But I think a lot of that is because we quit educating and talking with the faith leaders. Number 3, poor customer care from health providers. Basically, echoes base camp she talked about this morning, and this recipe that GibStar always uses. The most effective models, Father Rick, the model that you helped develop with the leaders at EDARP. Most all of them have this bedrock of compassionate care in the staff that is supported and present. Then 4, reduced usage of public platforms and talking about HIV, radio, television, etc. 5, separating and segmenting ART facilities and services from others. It's exactly what made Echo and Harry in the beginning from the 2005 say, we are going to have to provide compassionate care because standalone HIV care is not going to work. 6, absence of community-based HIV testing and treatment centers. People had to travel too far. 7, fear of being judged or isolated. And 8, erroneous application of religious doctrines such as faith healing. And is Canon Gideon here? Is he here this morning? I thought I saw him early. Oh, okay, there you are. So when I asked GibStar what happened in Zambia that changed things, he said, when Canon came to visit and spoke at one of our churches, his example really eliminated stigma largely from within the church congregations, which I thought was amazing. I mean, a lot of times we think, what is the power of one? But if the one is the right one, the power can be phenomenal. I mean, we've heard that you've gone from one person, a faith leader affected by HIV, speaking about it, to 13,000. So we have big challenges like the pediatric ones, but I'm certain we can make a difference. Next slide, please. So here's some of the tools and strategies and methodologies that GibStar and the staff employed to address those drivers. Building capacity among community influencers to disseminate accurate information, number 1. And so those messages of hope do a lot of that. And, speaking to our previous speaker, we have a very robust social network platform that we're using digitally, and we've been doing it for about 4 years within the faith communities that it'd be great to talk with you about, and we can link you to it. To publicly addressing myths and misconceptions and misinformations on HIV, both in the local community and congregational settings. And then 3, building the capacity of the health providers and faith leaders to spread positive messages. I want to say one thing about the reason some of the methods of ECHO and some of the baby shower methods, some of the methods that are most effective at actually getting tests and treatment to those who most need it are the ones that include celebration and positive messages. Number 4, provision of support to faith community networks and structures, things like volunteer allowances or psychosocial counseling, addressing depression, suicide, or household poverty where feasible. 5, provision of support to the older if you're needing to access COVID-19 services in congregational settings. 6, provision of unhindered access to the HIV community centers, these circles of hope embedded in the communities, the little posts, and provision of mobile HIV centers and help desks to help in churches and mosques. So if there's questions that faith leaders have, while they're already at their services, can get them answered. And 8, provision of excellent customer care through love, care, and responsibility, and this recipe. Next slide, please. So I want to talk a little bit about the targeted HIV testing, and it's really based on the approach of leveraging relationship capital. In the business realm, they talk about various different kinds of capitals, and one of the main kinds of capital is relationship capital, and that really is what the church and the faith and mosque, the faith communities, can leverage. So the overall strategy was to decentralize service delivery to the community level where community influencers and leaders have direct impact on community decisions and individual decisions. And the specific strategies were to identify, segment, and map the faith and local communities in specific areas that were within 2 or 3 kilometers around a facility or community post, and then to foster and strengthen collaboration between the faith networks and the community networks and the markets and business networks within those areas. And what was really amazing is because of the unhindered trust and access that faith leaders have to households, and because they really are your best deal on the market for social capital, honestly, because that's who people talk with about the things they're struggling with. What you see in that next bullet, the bottom one, Circle of Hope has grown from the number currently on treatment for HIV when they started 2.5 years ago, and I first saw them. There were only 3,500 people in their clinic system when they were sitting waiting for people to come that were on treatment. In 2 years and 8 months, basically 2.5 years, that number has almost multiplied by 10. It's now 28,000 people. And honestly, it is something very simple of, it's not just the people providing the service, it's the place. From, honestly, from the Garden of Eden, people and place were always important to God. And I think of this all the time when I see data, because you have to pay attention to both. And not just who are the people who need the service, but who are the people that are delivering the service, and are they trusted and kind and compassionate and caring? Because if you can do that in Zambia, you can do it anywhere, and we can find all these people that are missing. And then finally, what I was talking about, Circle of Hope has scaled its model within Zambia. Now it has 150 community posts in 4 CDC-supported provinces, and additional ones by the Ministry of Health, and also expanded to Nigeria and Zimbabwe, with more countries to follow. Next slide, please. So they particularly had strategies for men and strategies for children and adolescents. I'm going to briefly go over those. Again, the social networks, having expert male clients link their friends to testing for HIV. And what was fascinating is I met a pastor who was about 50 who had just been diagnosed with HIV in one of these community posts on another visit. And he was one of the main spokespersons, and a little bit like you, I think, Cannon, when you have faith leaders who are transparent about their status and living with hope and are trying to help spread that message to people, it's very influential. And then certainly using male leadership to promote HIV sensitization, working with female sex workers, because often they have an average of 2 to 3 male clients, that they can certainly, at least that many, if not a lot more, that they can refer. And then providing private health talks in social places to encourage men, like not necessarily only at the church, but out, having a Coke somewhere, or at another outing, encouraging men who are ready to go for testing. Next slide, please. And these are strategies to identify children and adolescents. Lessons, they took the lessons that worked for finding the men, and they thought, how could we adapt these and use them to help us find the children and adolescents? And they're working well. They had to choose the time that was more convenient. Kids are in school all the time, and so needing to come after school. There were some custody challenges because at times the guardians were not paying as much attention to this as potential parents. And often if it was the guardian of a child who had been orphaned because of death of parents, it was not necessarily true that someone was thinking we need to have the children tested. At times there's a lack of safe spaces and facilities. Uganda is great. Mango Hospital, they have a Saturday-only celebration kind of day for adolescents living with HIV, and they're the only ones that can get served on Saturdays. And then some of this lack of adolescent and child role models. But I do want to say we have a remarkable intervention for that called the CATS program. It's been tested in randomized trials in various countries and supported and adapted for the Faith and Community Initiative. So again, I would say often the problem is not that we don't know what works, it's that we are not using the research that shows what works. Next slide, please. So other strategies, late disclosure is a barrier to adherence, and so encouraging and helping parents to disclose earlier. The CATS groups do that. Low household income, sometimes that influences transportation, and so even trying to encourage nutritional support and cash transfers where appropriate and linked to those services. Congestion at facilities, again, having separate times, and treatment fatigue means there needs to be continuous celebration like this model, Operation 000, that I think, Father Rick, you were involved in developing, is really helpful for kids. Next slide, please. And so I'm going to talk a little bit about the results. I'm going to walk through some of them quickly because some of them I showed yesterday afternoon. How many of you were here yesterday when I gave the closing talk? Raise your hand, please. So most of you, great. I'm going to go really through quickly some but not all the results. Next slide, please. So this shows this massive increase from the time, I visited at about that first blue arrow on the left was when I visited, and they were just getting ready to start the community post, and I visited kind of between the first two arrows, and we began to see some glimmers of, oh my goodness, this looks like it's going to work, and then we saw this really dramatic upswing until Q1 of 2020, and then you saw the new positives start going down, but that's because when COVID hit, they suddenly expanded to other regions of the country providing the same things, and other regions providing the same things, so they no longer were, they're not the sole provider. Next slide, please. So this is fascinating because not often, I'm just going to talk about the circle on the right. I was making a big deal of Zimbabwe yesterday about having equal, using this model, faith-engaged community posts, equal positives in men and women. Well, this was really amazing because what Circle of Hope found in Zambia is they even found more new positives in men than in women using this model. It was so appealing to the men. I remember going in the first one I went in, I was in a market, and there were some dried pinto beans on a little table outside, and it looked every bit like you're going to walk into this little doorway and buy beans. But you walked in there, and there was a little clinic, and everybody there waiting to take care of you, including some faith leaders ready to counsel you if you had any questions. Next slide, please. So I showed this slide yesterday, but a few of you were not here. Again, I've said if there's one slide I think of that needs to go around the world, it's honestly this one, because you see what happens in the red yield for quarters 2 and 3 in the community post, right, that were faith-engaged community posts, engaging the faith leaders who had the social capital and knew the community, and they were getting 27% to 35% yield. In contrast, when the governmental health office tried to replicate the model and just put community posts in place but did not put the faith-engaged part of the trusted leaders in place, still this kind of yield in men is very impressive, 7 to 11%. But you see that if you have the right people who are trusted offering the right services, you get a yield 3 times as high. Next slide, please. So this is just from a while after they had started, how you see those on treatment continuing going up. Next slide, please. And then this is, they had to work on viral load suppression because the key to making this work is you have to be able to get everything you need of that community post. The testing, the treatment, the viral load draw, and knowledge of your results in your viral load suppression. And it took a while for them to get that working, but now it's working great. Next slide, please. I didn't have time to say anything about this yesterday, but it is so impressive, and I want to only start with that tall red bar that says 4,294, and that is the number of index contacts elicited. And with our knowledge that we have to emphasize indexing so much and finding the sex partners and other family partners and testing them, it was really remarkable that they had a 1 to 2.4 elicitation ratio, and 86% of those were tested next to the right, and they had a 52% positivity yield in those who they tested who were index clients. And again, I think it's because they do such a great job with their trust capital of getting people to trust them to identify people at risk, but they also take a different approach. When someone's positive, they will say, Congratulations that now, because you know your status, you're going to be able to save the lives of the people that you love most, because we together are going to figure out how to let them know they need to be tested for HIV. And we will accompany you. We will do it in a way that you're most comfortable with. And this is going to be a good day for you and a good day for people you care about, because now you're not going to have to risk that you're going to get sick from HIV/AIDS because no one, you never knew, and your people, the people in your family you love never knew that they were positive. Next slide, please. Thank you. So I guess, do I have questions now or later? Later?
Thank you, Suzanne. Excellent presentation, considering that it was not your presentation. Taking into account the time, I wonder whether we could have one question from the floor, or a comment, and then maybe from the people online, because we have another session coming. There's one there. Please say to whom you address your question.
Okay. I'm Jane Nganga. I work for INERENA. My question goes to Suzanne. If there is anything good that happened within the faith communities, was the faith community initiative and brought a lot of life and a lot of change at the community level, especially because of the engagement of faith leaders and going beyond the boundaries of the faith community to also engaging with the community at large. I have two questions. Number one, the whole issue around accessibility of HIV self-test kits. I remember it was phenomenal. The accessibility, people knew I need to rush to a faith community and I'll get my test kits. I know the pastor or the imam will be available to take me through the process, counsel me, and all that kind of stuff. But since then, we do not have the availability of the HIV test kits. We still get calls and people asking what happened. So maybe, I don't know, you will guide us. The number two is around sustainability of the initiatives that were started. There was amazing initiatives, but then it ended. How do we move from here? Thank you.
Great questions, and they're not easy questions. And so let's talk a little bit about your second question first. So, you know, the Faith and Community Initiative was funded as a one-year initiative under Ambassador Birx to identify effective models, and we did that. And we did that with a lot of you in the room. We did it together. Those effective models are now in standard COP guidance, and every country is urged to integrate and implement and support some of them. And so I think one of the things that's been a real challenge for you at the country level, and I would say for me also at a headquarters level, is it's very hard to get people to do new things. I mean, that's why behavior change is so hard, and people tend to support the same partners that they've had. In some countries, they have integrated the faith-based works remarkably and are continuing to support it. Zambia, for example, Zimbabwe has figured out a way to do it. And in other countries, that integration has not been as effective. These meetings that you have in countries where there is the opportunity to talk with the leadership of the Global Fund and PEPFAR offices in country, the fact that now we have new priorities, especially children, and we have models that really nobody else has, I think, models as effective within the faith-based communities at finding the pregnant women, because either they or their mothers or fathers are in a faith network somewhere, and they totally can be found. And their children with this baby shower celebration model can totally be found. So I don't know what to do other than, I think there's gonna have to be more and more advocacy. And all of us are going to have to do that together. So it is a hard question. I often have been frustrated by it myself, and I think we're going to have to try to together move political will forward. And I think that's one of the things that we heard Chip Lyons say from EGPAF, is that the main problem is not that we don't have tools and we don't know what works and we don't even know programmatic models. The main challenge is political will. So honestly, sometimes the thing that most helps with political will is a horrible number. That horrible number we heard this morning of only 41% of children have viral load suppression is one that we all should find it won't fall out of our minds, and wherever we are, we can advocate for them. So that's your second question. Remind me your first question. I'll give a shorter answer to that one. Oh, HIV self-test kits. Yes, in the middle of the pandemic and COVID, there were so many stockouts for HIV self-test kits, and I think that has continued to be engaging the faith networks. Some use them really well. Some countries use them deplorably. It's like giving them to everyone in the congregation is not effective because you get a 0.5% yield. But targeted use, the data from EDARP is remarkable, and I think really the best in the world for that, is so effective. We don't have any reason not to be using it. And so I think that the only thing we could do is keep advocating for it. But honestly, I was listening to what you were talking about this morning and the potential to buy them at cheap costs. At some point, it may end up being like contraceptive supplies. Sometimes people have to pay something. And if you can get a HIV self-test for $1, it might become within the realm of possibility even for people who need it to buy it. So that's my only thought about that. And again, I just respect and honor all of you so much. And if there were any way I knew to move political will, I would. And certainly we all, I think, are trying together. Thank you.
Thank you. There's one question, there are two actually, but I will ask one addressed to Pove or Rachel from Daniel. It says, how can we handle self-confidence to self-testing? Some people doubt the result, mostly when it is positive.
Well, I think it's up to all of you here and everyone in the faith communities who is involved in self-testing to really reassure people that these tests work and that people can do them just as well as professionals. We've seen this in so many different groups. People, you don't have to have high literacy. You can still do a self-test. I think we've seen that during COVID. Maybe the first time somebody will need a little bit of a demonstration. There are virtual platforms where you can see how to do them, but people can really do them. But there are two caveats, and again, this is why the messaging is so important, that a positive test, whether it's done by a professional or by yourself, always needs confirmation, because there can be false positives, and nothing is perfect. We know when we go for a blood pressure check, sometimes it's high, but then when you repeat it, it's low. So you always, every single medical thing needs a check. So somebody needs to have that checked. And a negative test, of course, if you had an exposure the day before or the week before, that negative test won't be true because the antibodies haven't developed. So these really important messaging need to be given by the people who are distributing the kits.
Thank you.
And just have people around who, if you can't read it or you've done it wrong, all of us who've done COVID self-test, who's done a COVID self-test here?
Yes.
I'm sure we found when we opened that packet that first time, we were a bit, are we going to do this right? Sometimes we might not have done it right the first time, but you learn. And people can help each other just to show them how to do it.
Thank you.
They're fantastic, fantastic tests.
Thank you, Rachel. The same question is addressed to Father Rick.
I mean, two things. And the model we used with the faith leaders, we offered, once we found the person, then the faith leader would say, would you like me to stay with you while we do this together? The vast majority of people said yes, which really surprised me. So that gets to that together we can trust this. The other thing is, I made it a threat of God's wrath. You do not use the word positive with HIV self-testing. We use reactive and non-reactive. Positive is only for clinic-based testing. That's what we found really helpful. Self-testing is reactive or non-reactive. HIV clinic-based testing is then positive or negative.
Thank you so much, Father Rick. There's another question addressed to Rachel or to Povi. I would also like to know what WHO is now advising about the use of HIV self-testing kits for children. A quick one, I think.
This is my favorite question. What does self-test mean? It means testing yourself. You should never be forcing anyone else to test or test someone else. I totally agree with Father Ricks. It's great to have a professional with you. And this is what I think should be done for testing children. I think putting the responsibility on a mum or a dad to test the child is too much. And we don't at the moment know, we haven't got enough evidence to show that for all people that's a really good approach. We'd much rather, and we recognise that there will be kids out there who've missed the opportunity to test. It'd be really great if they could be tested in their home. But we'd much rather that was done by somebody who can be really supportive. Again, back to Father Rick's point, you may get a reactive test in a child, and it may be a false reactive one, so they need to go and be supported to go to the clinic, have that repeated, and then started on treatment. And that journey really needs somebody who can support that mum or that dad or that auntie who's looking after that kid. So we're not at the moment, we just don't think handing out kits in a clinic and saying you can go and test your children is going to be something that is going to be, without problems.
There's another question, but I think Susan can answer that question in writing. Or should we give her a minute to answer it? Okay. Susan, thank you for the presentation. And can you tell us more about the work Circle of Hope has done to encourage early disclosure? And are there other best practices that PEPFAR has supported by other faith community projects?
Yes, thanks a lot. So the other projects, I think the most studied and documented with the most impressive results within faith and other communities is the CATS program that was out of Zimbabwe, Child and Adolescent Treatment, CATS. I can't remember what the S stands for, but it's, if you search it as CATS, Adolescent HIV treatment online, you'll get the last S, but it's commonly referred to as the CATS program all the time. And it took in Zimbabwe, in the first randomized trial, it took viral load suppression from something deplorable like 38% up to 84%. It was just phenomenal, and it has been replicated in about 10 countries. So it's amazing. So that's that. And with Circle of Hope, they're so good at really trying to explore the family. So with, as if there's a man or a woman who is newly positive, they will always begin to ask about the children and if they have been tested or not been tested, and if they're on treatment or not on treatment. And so they will try to help accompany the index person to disclose to the child. And then another thing that is quite common that I'm not really sure, like for example, the UN and other communities know about, it's really common in churches, and I don't know about mosques. I do know about churches because I've seen and heard of a lot of them. is to have small youth groups that meet in the Church of Youth Living with HIV for support. One of the most effective models at finding them and helping disclosure is the co-location model described in the COP22 guidance that was initially developed by Discover USAID in Zambia. But what is the co-location model means is that you have a church or a mosque, and on the grounds is room for a container or a little trailer clinic, a small PEPFAR or HIV and other care clinic, a few other things, not only HIV, but primarily HIV. And the first one I visited in Lusaka, it was fascinating because the youth living with HIV refused to go to the clinic to get their care, but they met every week in the church for a support group that included positives and negatives, which was fascinating. I think some of the support that we heard about from Jeannie yesterday was really present, but those who are positive wanted people to come over there and examine them there and give them their medicine in the church because they did not want to go to the clinic, which I just thought was fascinating. So the faith groups are doing a lot, some described, some not described, some remarkably evaluated, and if adherence is and disclosure is what you're most looking for, the CATS model is remarkable.
Wonderful. An applause. Thank you. Over to you, Francesca.
Thank you, everyone, and thank you to the speakers and the WHO representatives. Just to say also that we prepared some years ago, Rachel, if you remember, a briefing on HIV self-testing for communities, including faith communities. It might need to be updated, but I think it's something we can circulate. And we are going to now move to the other session, and thank you, everyone. And we're going to have some music before the next session.